Uh, Thank you very much, Ji, for inviting me. Can everyone here at the back? Thank you guys for inviting me here to talk about the thyroid disease. सबसे पहले जो नासिर ने मुझे पहले बुलाया कि जी आपका सेशन लंच के बाद होगा, तो इट वाज ऑलरेडी ए चैलेंज फॉर मी. खाने के बाद पोस्ट प्रेंडियल हाइपर स्लीपनेस आपकी सबके हम सब में प्रॉब्लम होती है. तो दैट्स व्हाई आई विल ट्राई टू कीप दिस लेक्चर एज इंटरेक्टिव एज इट कुड पॉसिबल बी. दैट्स व्हाई आई एम नॉट स्टैंडिंग एट द बैक ऑफ द पोडियम, क्योंकि मैं पता है वी टेंड टू स्लीप डोज ऑफ मच मोर ईजियर. बट अगेन अगर किसी ने थोड़ी सी नैप लेनी है, इट्स ओके विद मी. वी कैन ऑलवेज हैव टाइम एट द एंड टू डिस्कस एनी थायराइड रिलेटेड क्वेश्चन दैट यू माइट हैव. The other point that I want to address is that thyroid disease, when I was given the topic of thyroid disease, I personally think it's not something that you can discuss over 1 hour, 145 minutes or 30 minutes. It is something that we really have to go into detail. The problem, इसकी एक जो principal वजह यही है कि we usually tend to label every thyroid disease in one chunk. I spent 2 years studying about thyroid disease. I know कि हर disease का protocol फर्क होता है. And again, knowing what I know now, I think this has to be done in a more systematic way rather than just staying at the goiter and doing all the lab tests which shouldn't be required. Because I've been seeing a lot of investigation on, obviously, being referred from all of you guys, जिसमें necessary or unnecessary tests at the same time have been done on a patient, which has a lot of cost implication. That's why I will try to refrain myself on typically 2 topics. One is hypothyroidism and the other one is hyperthyroidism. And again, I will not go into details of treatments, I will not go into details of investigation choice, but I'll give you some basic guidelines, who to screen, how to screen and when to screen. That's the bottom baseline what I'll try to address. And obviously अगर कोई चीज़ miss out हो जाती है, I'll leave 5-10 minutes in the end. If you have any burning question that I could address, I'll be more than happy to do. So without further ado, I would like to go ahead with my presentation. First, without even going into the pathophysiology of the thyroid disease, I would like to spend some time on physiology, and again not more than 2 minutes, on how the thyroid hormone really works in our body. And this is not something which is very difficult, so it will be easier for me to explain it to you guys. We have hypothalamus in the brain, then we have pituitary gland. TSH is the regulatory hormone which is secreted by the anterior pituitary, which gives stimulation to the thyroid gland itself to produce thyroid hormone. So how does the whole scenario works? How does everything fall into one place to help us maintain a thyroxine level or the hormone level that we need to have? First, the TRH is a thyroid releasing hormone which stimulates the pituitary, anterior pituitary, to release TSH. And I would address this point, I would like to address this point now, that the TSH is produced by the master gland in our brain. So whatever our brain can sense, sometimes we as a clinician cannot sense. So I totally and solely rely sometime on the TSH to give me an answer for thyroid disease absence or presence. And this is important because especially when we are screening someone for a thyroid disease, because screening is something that you want to make sure what other investigation we need to follow after we do the first screening part. And that's why TSH is the most important thyroid test in my book. TSH goes into the thyroid, obviously stimulates the thyroid to make T3, T4, which we know is a thyroid hormone. T3 is more bioactive, more active than the T4. Obviously T4 gets converted into T3 in the periphery to make its action. Some of the T3 and T4 goes into the liver, get conjugated and excreted through the bile and whatnot. If you look at the T4 circulation, apart from going through all our body, it goes back in our pituitary and it goes back in our hypothalamus. And the main purpose of this hormone going back to our brain is to help guide the master gland how much stimulation it needs to push to make more hormone or to make less of hormone. Because if your thyroid hormone is more, it will inhibit the pituitary as well as hypothalamus, number one. Or if it's less in the circulation, it will ask the pituitary as well as the hypothalamus to go up. So always remember that in a hypo situation, when there is less thyroid, TSH will go up, and if there is increased production, TSH will come down. And I think if this has been point which all of us understand, it will be much easier for us to interpret the lab testing as we go along. Let's talk about the primary algorithm when we talk about the thyroid disease. Not spending too much time, because I know there's multiple reasons that you might see thyroid test being abnormal, but I listed down few of the causes of hypothyroidism, and in here I'll try to show some of the causes, such as autoimmune thyroiditis. Iatrogenic means something that we did medically or non-medically. If we had someone has a thyroid taken out, thyroidectomy can cause hypothyroidism. Obviously radiation therapy, radioactive iodine can obviously knock your thyroid down and produce hypothyroidism. Iodine deficiency in excess, interestingly both of them can cause hypothyroidism. Medication, one of the major culprits of causing hypo and hyperthyroidism are the medication that we give. I think thankfully these medications are not used as often as we would think. Amiodarone, interferon, interleukin, these are all cause thyroid abnormalities. Transient hypothyroidism, although is not a very common phenomena, but again can be caused by subacute thyroiditis, can be caused by postpartum thyroiditis, subtotal thyroidectomy, because if someone's gland, half of the gland is working extra, if you take that gland out, the other gland which has been resting for years will tend to be sleeping for some time, and then it kind of picks up and starts working. So in those scenarios you would see a transient hypothyroidism, and these people tend to go back to their normal thyroid function when the other half of the thyroid takes up the work. Obviously some of the central causes, such as TSH deficiency or TRH deficiency, if the brain is not sending enough signals, thyroid will not work if your brain is not sending signals. So you need your brain to send signals to make thyroid hormone. So if there's any fault in the brain, in the pituitary gland or the hypothalamus, you will not see the production of thyroxine. But obviously very, very rarely thyroid resistance syndrome can give you hypothyroidism. I threw in this slide not because I wanted to teach everyone what the symptoms of thyroid disease is, but just to remind everyone that thyroid disease is such a vague disease that it's almost impossible to put your foot down and say this is the patient who has a thyroid disease. And usually I give the example of many few patients in which I could swear that they had thyroid disease, and you check their thyroid function test and they're perfectly normal. And at this point I would want to address that thyroid disease is not something that you want to treat just on your clinical basis. You need your biochemical evidence too before you start treating anyone with any hyper or hypothyroidism, because you can be misled by the symptoms of the thyroid disease. And why do I say that? If you look at the fatigue, weakness and muscle cramps and aches, how many people in this room do not have this? Coarse hair loss, how many? Weight gain, dry skin, cold intolerance, constipation, irritable, memory loss, depression, menstrual dysfunction. If you could look at all these symptoms and signs, these are the symptoms which are very much prevalent in our society, in any society for that matter. So unless you have a biochemical evidence to prove that someone has a thyroid disease, it's not recommended that you start treating patients with thyroid disease. Can we shut off the light? Can we shut the light off? Okay, I think if it's not showing up clearly, I apologize for the poor quality, but I hope everyone can see at the back. Now what I'll try to do in next few slides is try to go over the algorithms of hypothyroidism. With that I'm meaning primary hypothyroidism. So I'm not talking about the secondary or tertiary hypothyroidism, which is due to the problem in the pituitary gland or the hypothalamus. So again, like any other case of thyroid disease, the first test that you should be looking at is a TSH. First look at the TSH and then decide which direction you want to move. You're suspecting someone with hypothyroid symptoms or hypothyroidism, you check a TSH. If the TSH is less than 0.5, the patient has hyperthyroidism, means the thyroid body is producing a little too much of thyroid hormone. So the reason I put it here, because the symptoms of hypo and hyperthyroidism both can sometimes mimic each other. So it's hard to differentiate just looking at the patient. So if this patient TSH is low, you think of primary hypothyroidism and you treat accordingly. There is another condition which I'll talk later on, in which the TSH is low and the patient is still hypothyroid, and again that's because of the brain. If brain is not sending signal, the TSH will be low and the thyroid hormone will be low. Okay, and if you check a TSH and if it is 0.5 to 5, which is a normal range in most of the labs, then this patient is euthyroid. Look for other causes of the symptoms the patient has been experiencing. But there is a caveat to this, and I'll explain it in the next slide. What do I really mean if the TSH is between 0.5 and 5? Sometimes we tend to forget what's the importance of a TSH of 5 even. Lastly, if the TSH is more than 5, then you look at the free T4. And the importance of free T4 is helping you decide which way to go. Just to give you an example, if your TSH is low, if TSH is high, and your free T4 is low, then obviously you have a patient has hypothyroidism. You treat it according to the algorithm, which we can discuss at the end of the lecture if you guys are interested. If the free T4 is normal, that's a condition that we used to call more often subclinical hypothyroidism. It's hard to say that these people are subclinical because they do definitely have clinical symptoms. So it's a misnomer to call them subclinical. What we now call it more often is something like mild thyroid failure. If the TSH is high but their free T4 is normal, then we call it mild thyroid failure. And obviously if the free T4 is high, if the TSH is high and the free T4, which is the actual circulating hormone, is high, this is something which is very, very rare and can be produced by a tumor in the brain, in the pituitary gland or the hypothalamus, leading to high TSH and high free T4. And the other rare condition that can lead to high TSH and high free T4 is a thyroid resistance syndrome. I think if we understand this slide during this next 15-minute lecture, I think my job of discussing thyroid disease is over. Although I have many other slides in this in the presentation, but I think this is the most important slide. And why do I say that? And let me try starting. Let's start by going through it one by one. This is a condition in which we all call mild thyroid failure, which I talked about earlier, in which there is a normal T4, and this is something we see all the time. Again, I want to stress here one small point, that I keep saying normal T4. It does not mean the total T4 that we usually check for. It means the free T4 hormone which is in the body. This is available in all the labs, pretty much all the labs in Lahore, in Punjab, in Pakistan. But people are not using it enough. Free T4 is the actual hormone level which is biochemically active in the body. It is not the total thyroid T4, because the total T4 could be misleading in many conditions. So what I usually do, and again this is something I try to preach, and this is a trend in all over the world. If you're looking for a thyroid disease, look for TSH. But if you want to further investigate, look for free T4 and not the total one. And the cost implication are not that much different anyways, because the total T4, almost with 100 rupees or so difference, you can get the free T4, and it gives you much more information. So again, coming back to the person who has a normal free T4, circulating normal, how should you proceed? So I divided that into the 4 categories. 4 categories mean someone whose TSH is between 0.4 and 2.5. Remember, I did not put 5 here. I'm looking at the people who have a normal, and that's where the 90% of all the normal individuals fall into, with a TSH of 0.4 to 2.5. If their free T4 is normal and their TSH is between 0.4 to 2.5, you do not need any follow-up. You look for other causes of their symptoms. If the TSH is between 2.5 and 4, and these are the people we tend to neglect all the time. These are the people who need monitoring at least annually. Why? Because their TSH is already on the upper 10 percentile of the population. These are the people these might be the people who are going to develop thyroid disease in 1 year's time. So you have to keep your eyes open on these specially subset of people to make sure that they are not developing thyroid disease in coming years. Okay, what about the people who have a TSH between 4 and 10? These are the people who what we call now a mild hypothyroidism. It's not called subclinical hypothyroidism in most of the international organizations. These are called patients with mild hypothyroidism. When do we need to treat? These are the patients in which there is no clear-cut indication of start treatment. You can either monitor them closely over few months to see if their TSH goes above 10 or if their TSH normalizes, or you would start treating in certain subset of group of people. And who are those people you would want to start? If someone has a positive thyroid antibodies, these are the individuals you would want to start treating, because thyroid antibodies could reflect the thyroid disease in earlier phase. Personal history of thyroid disease. If someone has a thyroid disease in the past, hypo or hyper, they are more likely to develop thyroid disease down the road. And again, these are the people you want to start them earlier than waiting till they become fully hypothyroid. Family history of thyroid disease. If they are desiring for a pregnancy, and this is a newer data that has come lately, that the pregnant women have to have, if they are hypothyroid, they need to have their doses increased at the time of pregnancy, because their kids totally depend on their thyroid for their mental and developmental needs. So if someone is if someone is already diagnosed with hypothyroidism and they become pregnant, their thyroid dose has to be increased, and that's where it's coming from. And if their TSH is high, they are not on thyroxine, and they are pregnant, you might want to start them on thyroxine, because for the first 13 weeks the baby is totally relying on their mother for the thyroid hormone, and we all know how much thyroid is important in the early phase of development. Elevated total cholesterol or LDL, and obviously symptoms. The final subset of group in which the free T4 is normal but the TSH is more than 10. These are the patients who all the international organization would say start treating. Why? Because there is enough data in literature that all the patients with a TSH of more than 10 should be started on treatment. If you want to wait for 1 month to repeat the TSH to see if it's coming down, that's fine. But usually after 10, I usually don't wait and start them on treatment. The patient in which we need to be very careful, again, I'm not going to talk about the whole treatment algorithm, but again, the patient we should be very careful in starting a treatment with thyroxine is a subset of patient I've written down. Elderly mean very old people who have other comorbid conditions. Atrial fibrillation. If someone has already atrial fibrillation, then you need to make sure that their fibrillation might get worse after thyroxine preparation. And obviously ischemic heart disease are the patients who should be careful.
So what could be the condition of T3? Do you wish to have T3 activated over there?
That's a very good question, and this is one of the most debatable questions at this time. Some people say if your TSH is normal, your free T4 is normal, do not treat T3 levels. But there is a big chunk of people who say that the T3 is very important because that's the most bioavailable hormone level in our body. They say start treating that. Even treating with T3, because in Pakistan we don't have T3 pharmacologically available. We only have T4. Thyroxine is T4, which gets converted. My catch is I don't think there's enough evidence to look for T3 deficiency and start treating for T3 deficiency, because if your liver and your body is working perfectly fine, they will change the T4 to T3. I have seen multiple cases in which there were T4, TSH was normal, T4 was normal, and T3 was undetectable. In my book, it doesn't make any sense. I would just repeat the test and order the free T4 and TSH and then go from there, because T4 does get converted into T3, and there is hardly any deficiency which would cause a complete stoppage of T4 T3 conversion. There are medications, there are things, but it does not completely stop. So answer your question, there could be a role down the road, but now the clinical evidence is not there to check T3 in each and every person.
Do you think if we leave them untreated, we turn out to be hyperthyroid within 5 to 6 years?
If you don't treat, I will need to clarify the question.
If you don't treat these cases, and there is overstimulation of TSH, will they cross over from hyper to hyperthyroidism?
Excellent question, and I think that's why the first slide was very helpful. I totally rely on my pituitary. Every one of us rely on their pituitary gland to help us define how much thyroxine we need. That's why once I make the diagnosis of hypothyroidism, I don't look for T4, T3, I just look for TSH. And to answer your question, would high TSH lead to hyperthyroidism? No, because the TSH, as soon as the T4 starts coming up, TSH will come down until unless there is a problem in the brain. And again, that problem is very, very rare. Again, few minutes on this slide. What are the risk factors of someone going into a fulminant overt hypothyroidism if you are seeing the earlier signs of hypothyroidism? If you are seeing a person with a mild thyroid failure, what are the predictors of in the patient which will help us define if they were going to become hypothyroid down the road or not? Again, there is no gold standard for it, but I jotted down few here. If someone's TSH is more than 2.5, if you remember my last slide, they are more likely to develop overt hypothyroidism, clinically significant hypothyroidism down the road. If they have a goiter signifying autoimmune disease, they are more likely to develop hypothyroidism. If they are antibodies, antithyroglobulin antibodies, antiperoxidase antibodies, they are more likely to develop thyroid disease than if they are older, if the person is female, if the family history is positive, and obviously this is not significant for our part of the world, obviously, but again, if they are genetic predisposed towards getting hypothyroidism. These are the patients which we should keep a very close eye on when we start treating, when we're looking at the TSH value of these patients. I mentioned briefly about the thyroid antibodies, but there is a caveat to it. I hardly ever use thyroid antibodies for making a diagnosis. And why is that? The only time I would use thyroid antiglobulin antibodies or any antithyroid antibodies assays is when I am stuck between starting a treatment or not starting a treatment. To give you an example, if someone TSH is just staying at 6-7 on 2 repeated occasions after 6 weeks, these are the patients who are having clinical symptoms and we don't know if we need to start treatment or not. These are the patients I will look for antibodies. But in all the other scenarios, number one, the cost effectiveness is not there. Number two, they do not add any value as far as treatment is concerned. Why? If you look at this graph, this will explain it why. In general population, 20% of the patients who do not have thyroid disease have antithyroglobulin antibodies positive. 28 to 27% have anti-TPO antibodies present. So again, in general population, these antibodies could be present and hence they will not add to any of the treatment plan that we might have for the patient. What are the other conditions which have antibodies? The only significant positive antibodies which might help you in a diagnosis in a very certain small group of patients is antithyrotropin receptor antibodies, which are only present in Graves' disease and autoimmune thyroiditis and is not present in any of the conditions. So they might help you define the diagnosis, especially if you cannot do a thyroid scan or uptake on certain individuals. But again, if you look at the antithyroglobulin antibodies or anti-TPO antibodies, they are pretty much present in type 1, in pregnant women, in relative with autoimmune disease, in autoimmune thyroiditis, Graves' disease, and same is true with the anti-TPO antibodies. Again, emphasizing the point, there is no as such need to start looking for antibodies when you are seeing round-the-mill thyroid patient. But obviously, if you're stuck in a certain condition, and again, this is a whole topic that I can speak for an hour, that there are certain conditions you need to look at the thyroid antibodies, but the rest of the conditions you can just pass them. Here I wanted to just give you a brief history. We all know the benefits of treating hypothyroidism, but what are the real subtle changes we tend to ignore when we're seeing patients with a hypothyroidism or not so clear hypothyroidism, or what we call mild thyroid failure? They definitely have effect on the total cholesterol and LDL. If you remember the slide before, if that is high and patients TSH is on a higher normal size, these are the patients you might consider even starting treatment for thyroxine, because the total cholesterol and the LDL do increase with the mild hypothyroidism, and in overt hypothyroidism it definitely increases. There is no change usually in HDL and triglyceride, although there are few studies which show the triglyceride also go up higher. Cardiac LV function decreases with the mild thyroid failure, and so is true with the overt hypothyroidism. So these are the patients, if they're mildly hypothyroid and their ejection fraction is low, you give them thyroxine, the ejection fraction might come up. Again, something clinical importance that we tend to ignore. Mortality, morbidity, both of them increases, so it puts at a higher risk of dying if you're overtly or even subtle hypothyroidism. And obviously there is no change in the bone mineral density, although the hyperthyroidism can definitely lead to bone loss and decrease in the bone density. Some of the reproductive disorders associated with hypothyroidism, obviously in women, we don't tend to check a thyroid as often as we should, especially someone experiencing irregular period, menorrhagia or oligomenorrhea, reduced fertility, reduced sex hormone binding globulins, hyperprolactinemia, increased risk of early pregnancy loss, and obviously early preterm labor. These are all risk factors for someone who is experiencing hypothyroidism. Again, something we need to tend. Before I go to the topic of hyperthyroidism, I would want to give just to all our family physicians one quick pointer. American Thyroid Association and most of the organization recommend that your TSH you should have a screening for thyroid disease at the age of 35, no matter if you're having symptoms or not, and then it should be repeated every 5 years if you don't have the disease. So again, even if you're not checking at 35, please check it at 35, at 40, or at some age whenever you're seeing the patient, because that's one of the diseases I think we are much under-treating, under-diagnosing as compared to any other disease. Now coming to the hyperthyroidism part of our talk, again just an algorithm briefly, and I won't spend too much time here, is if you're suspecting someone with hyperthyroidism, excessive thyroid hormone in the body, the first test that you do is a TSH. Again, for any thyroid disease, the first screening test is a TSH, because that helps you direct your treatment from there onwards. If the TSH is more than 5, obviously you need to treat them for more of a hypothyroidism than hypothyroidism. Again, why is that important? Because the symptoms of both can mimic each other and you could be easily mislead into one or the other. There's also a condition called apathetic hyperthyroidism. You might have all heard of it. These are the patient, in older patients, patient come in presenting as a hypothyroid. They have all classical symptoms of hypothyroidism, but actually they have hyperthyroidism. Actually thyroid is working high, but they present the totally opposite symptom. So again, that's something that we need to look into. What if someone TSH is between 0.5 and 5? Obviously, these are the patients who we can call euthyroid, who do not have thyroid disease. Again, we can argue about the upper limit being 5 and making sure that they are not developing high thyroid disease. But as far as hyperthyroidism workup is concerned, they are euthyroid. And obviously, if you are suspecting something in the brain, like the TSH is high and free T4 would be high, these are the patient who needs to go to a specialist care to make sure that we are not missing anything in the diagnosis. Obviously, in these patients, you can also check free T4 just to make sure if it's high or normal. And finally, in someone who's suspecting hyperthyroidism and their TSH is less than 0.5, these are the patients who obviously are most likely hyperthyroid. Then you go for the free T4. Again, I keep telling you about free. It has to be free T4, or you can even check in free T3 at this time to make a diagnosis of T3 toxicosis or not. And again, if their T4 is normal, if actually low, if their TSH is low and their free T4 is low, then these are the people you will suspect any problem in the brain. Again, that means that brain is not sending enough signals to produce enough thyroid hormones. Again, any lesion in the brain, and these are the patient who needs to be further investigation. If their free T4 is normal, again, these are the people which we used to call, and we still call subclinical just like subclinical hypothyroidism, these patients are called subclinical hyperthyroidism, because their T4 is normal. But again, if their T4 is high and their TSH is suppressed, these are the patients who are clinically and biochemically hyperthyroid, and they need to be investigated accordingly. How many minutes? 15 minutes.
Between T3, T4 normally, so should be understand that?
Actually, every lab, there is no ratio as such. Every lab has a certain set of values which they have set up according to. The question was, is there a certain ratio between T4 and T3 that we can go about? No, there is none. There is a certain
T3 at least 3-4 times higher than by nanograms.
No, because even the values is different from different labs, so you cannot have a ratio associated with. But if your T3 is higher and your free T4 is normal, that means you're going to a T3. In Graves' disease, the T3 is much higher than the T4. But I don't think there is any gold standard. You can make up any numbers. I can make up any numbers, but there is no gold standard ratio as such in which you look at and say this is a misnomer. Again, finally, looking at a differential diagnosis for hyperthyroidism, and I think this is my last slide. The differential diagnosis, whenever we are looking at someone who is hyperthyroid, is use of levothyroxine, euthyroid sick syndrome, Graves' disease, multinodular goiter, hyperfunctioning nodule, glucocorticoids treatment, dopamine treatment, and partial pan hypopituitarism, in which there is obviously low TSH and low T4. So how should we proceed as far as patient in which we are trying to make a diagnosis of thyroid disease is concerned? First thing that we look for is a TSH, and we knew that TSH was suppressed. The next test that you will do is look for the free T4, and that will help us define what we are heading out. Let's look at this next slide. If your free T4 is normal in a setting of a suppressed TSH, you look for the T3, as I was asking earlier. So you look at the TSH, you look at the T4, and that the T4 was low, then you look at the T3. Actually, T4 was normal. You look at the T3. If the T3 is low, then either you have sick euthyroid syndrome, in which the T3 becomes low, T4 is normal, and TSH is suppressed. This is a condition which is commonly happening in an acutely ill patient. These patients do not need any treatment. They just need a repeat thyroid function test in about 4 to 6 weeks. If your TSH, again, I'm repeating everything when I look at the algorithm. If the TSH is low, free T4 is normal, and the T3 is normal, these are the patients we call subclinical hyperthyroid. Again, these are the patients who need specialized care to decide if they need treatment or not. Finally, if someone has a T3 higher value with a normal T4, and this is something that I was discussing earlier, what we call T3 toxicosis. And I'll discuss the T3 toxicosis right here. And again, not to confuse everyone, but if you follow the algorithm, it becomes much more easier, number one, to do the minimum testing that's possible for the patient to reduce the cost, and to make everyone's life easier when we're seeing these patients. So if the T3 is high, or if the free T4 is high, you go for the thyroid uptake, which could be done with the technetium as well as a radioactive iodine. Most of the places are doing technetium. Shaukat Khanam is doing technetium, and I think Inmol is still doing radioactive iodine. But again, that's the test that you can go. So what if you look at the uptake, thyroid uptake, and it's low? Again, let's talk about the low uptake first. If your thyroid uptake is low, there are two conditions which usually causes this. It could either be silent thyroiditis, which is postpartum thyroiditis, or could be autoimmune thyroiditis. Actually, this is the entity I'm putting more stress on. Why? Because this is one entity we tend to forget all the time. Why do I say that? I see patient with a suppressed TSH, I see patient with high T4, T3, and they are on numercazole. Numercazole, which is an antithyroid medication, does not have any role in any of these conditions, because this is the condition of inflammation of thyroid disease, in which the thyroid is already spilled into your bloodstream, and numercazole will do nothing except to cause some damage to the liver. So these are the patients we have to make sure by the thyroid scan to make a diagnosis of thyroiditis versus hyperthyroidism. What on the next left arm of in the interest of time, I'm trying to short this presentation. Left arm if the uptake is high or normal, there are two possibilities. Either you can have a nodular goiter, or you can have a diffuse goiter on palpation. Nodular goiter will be very much clarified if you do the scan at the same time of doing the uptake, although the scan is already only done through the radioactive iodine. And again, you look at the radioactive iodine and see if there is a hot nodule or if the whole thyroid gland is working more. And that's why this is very important. If there is a one nodule or there are 2 or 3 nodules which are working extra, the rest of the gland would not show up on the scan. On the other hand, if you look at the Graves' disease, the whole gland will show up. So that's pretty much in as far as workup of hyperthyroidism is concerned. Before I finish, I would want to make a couple of comments as far as disease is concerned. I was in a meeting, in a family physician meeting, and we had a formal interview for a journal, and they were asking me, how come we are not seeing enough thyroid patients? Because if you look at the literature, the incidence is as high as about 3 to 4% in certain group of patients. But why aren't all of us seeing thyroid patients? They quoted they have 1,000 patients and they have 1 or 2 or 3 patients with thyroid disease. Why aren't we picking up thyroid? And my answer was as simple as we are not looking for it. I think we are not looking for the thyroid disease which is prevalent all across us. Number 2, we should avoid unnecessary investigation without making a clinical diagnosis. I see people who had the thyroid ultrasound, thyroid scan, thyroid uptake, TSH, free T4, T3, thyroid antibodies all done, and none of them were actually required. So again, these are the things that we have to, as long as we have a very clear black and white, that's how I believe in, as long as we have very clear black and white algorithm for treating thyroid disease, we are okay. And once you pick up, the best way to screen a thyroid disease is just by looking at the TSH and then deciding what we need to do. With that, I come to the end of the discussion. I'll take any questions. Thank you.